Hello and welcome. Today we're diving into a condition called hemorrhagic cystitis, a serious inflammation of the bladder characterized by bleeding into the bladder. We'll explore its causes, symptoms, diagnosis, and treatment, providing a comprehensive understanding of this condition. Hemorrhagic cystitis, or HC, can stem from several underlying causes. One of the most common culprits is infection, especially viral infections like adenovirus, which disproportionately affects children. Certain medications, particularly cyclophosphamide and ifosfamide, used in chemotherapy, are known to cause HC due to their bladder-irritating metabolites. Radiation therapy targeting the pelvic region can also damage the bladder lining, leading to HC less frequently. Bacterial infections, fungal infections, and autoimmune conditions may also contribute to the development of hemorrhagic cystitis. Understanding the cause is critical for effective management. Now, let's look at the pathophysiology of hemorrhagic cystitis. The inciting agent, whether it's a virus, medication, or radiation, damages the delicate lining of the bladder, known as the urothelium. This damage leads to inflammation and the breakdown of blood vessels within the bladder wall. As these vessels rupture, blood leaks into the bladder, causing the hallmark symptom of hematuria, or blood in the urine. The inflammatory process further exacerbates the damage, creating a vicious cycle of bleeding and irritation. In severe cases, blood clots can form within the bladder, leading to obstruction and further complications. While precise epidemiological data on hemorrhagic cystitis is somewhat limited, we know certain populations are at higher risk. Specifically, patients undergoing chemotherapy with cyclophosphamide or ifosfamide, individuals receiving radiation therapy to the pelvic area, and those with compromised immune systems, such as transplant recipients or individuals with HIV, are more susceptible. Children are also more prone to viral-induced HC. The prevalence of HC varies depending on the underlying cause and the specific patient population being studied. The most prominent sign of hemorrhagic cystitis is, of course, hematuria or blood in the urine. The urine may appear pink, red, or even dark brown depending on the amount of blood present. Patients may also experience other symptoms such as frequent urination, a burning sensation during urination, urgency, a sudden compelling need to urinate, lower abdominal pain or discomfort, and the passage of blood clots in the urine. In severe cases, patients may develop anemia due to blood loss. Diagnosing hemorrhagic cystitis involves a multi-pronged approach. A thorough medical history and physical examination are crucial. Urine analysis is performed to confirm the presence of blood and to look for signs of infection. Urine cultures may be obtained to identify any underlying bacterial or fungal infections. Cystoscopy, a procedure where a thin, flexible tube with a camera is inserted into the bladder, allows direct visualization of the bladder lining and helps to identify the source of bleeding and any other abnormalities. In some cases, imaging studies, such as CT scans or ultrasounds, may be used to rule out other potential causes of bleeding or to assess for complications such as blood clots. While hemorrhagic cystitis isn't typically classified into distinct types, its severity can be graded. It ranges from mild cases with microscopic hematuria, blood only visible under a microscope, to severe cases with gross hematuria, visible blood in the urine, and significant blood clot formation. The severity of the bleeding often guides the treatment approach. Treatment for hemorrhagic cystitis aims to control the bleeding, address the underlying cause, and prevent complications. Management strategies vary depending on the severity and etiology. In mild cases, conservative measures such as increased fluid intake and bladder irrigation may be sufficient. For more severe cases, medications to control bleeding, such as aminocaproic acid or tranexamic acid, may be used. In cases caused by chemotherapy, discontinuation or dose reduction of the offending medication may be necessary, if possible. Cystoscopy with clot evacuation may be required to remove large blood clots obstructing the bladder. In refractory cases, more invasive procedures like intravesical installations of medications such as formalin or silver nitrate, or even hyperbaric oxygen therapy may be considered. Blood transfusions may be necessary to address anemia. Preventing hemorrhagic cystitis often involves addressing the underlying risk factors. For patients receiving cyclophosphamide or ifosfamide, prophylactic measures such as adequate hydration and the administration of mesna, a drug that neutralizes the bladder, irritating metabolites of these medications, are crucial. For patients undergoing radiation therapy, strategies to minimize bladder exposure to radiation may be employed. Prompt treatment of urinary tract infections can also help prevent HC. Maintaining good hygiene and staying well hydrated are general measures that can reduce the risk of urinary tract problems. The prognosis for hemorrhagic cystitis varies depending on the underlying cause and the severity of the condition. In many cases, HC resolves with appropriate treatment and management. However, in severe cases or in patients with underlying medical conditions, HC can be more challenging to treat and may lead to complications such as anemia, bladder obstruction, or even kidney damage. Recent research has focused on developing new and more effective treatments for HC, including novel intravesical therapies and strategies to prevent chemotherapy-induced HC. Further research is ongoing to better understand the pathophysiology of HC and to identify new therapeutic targets.